So, okay. Aloha kako, we are now starting our lunchtime session, and may I please welcome to the stage two wonderful speakers. We have Courtney Sallings, who is a UAMS graduate, here to share her experiences about being a student.
Thank you.
Welcome. And we also have the pleasure of having Dr. Sheldon Riklon, who is also here to talk about his experiences in medical school and in the field. Thank you so much.
Thank you. Hey, everyone. I thought it would just be students, so I'm so glad y'all are staying. Not exactly, but. All right, so my name is Courtney Sallings. I was Dr. Nia's first student, preceptoree. I went to UAMS, College of Public Health, and I graduated in May with my MPH in biostatistics. So Dr. Nia and I got together to look for data on NHPI, which is kind of a nightmare, as you all know. And as everyone has been talking about, there are a lot of issues with finding this data. And so my goal was to find sources, organizations that held data, and to kind of list these and talk to everyone about how I did that. So the NHPI population in the U.S. is, so NHPI are the smallest major race group, but from 2000 to 2010, it increased 1/3 in size, and it's continually increasing. 7% of the U.S. population are Native Hawaiian or other Pacific Islanders, and over half of NHPI population reported more than one race. This is important because when we are talking about disaggregating data and self-identifying on demographic face sheets, we are looking at specifying one or more races, and how we identify these is important in looking at race-specific issues. So a lot of what we did was we looked at this model minority myth and how when you group two minorities together, like Asian Pacific Islander, Asian people may have really great health in certain areas that are opposite of Native Hawaiian and Pacific Islanders. And when you put them together, when you aggregate those, you can't actually see the truth of what's going on. So this whole model minority actually arose in the 60s. The media broadly applied the label of the model minority to newly arrived Asian immigrants. And Asian immigrants were upheld as models of racialized success in the U.S. And with NHPI being thrown under with Asian Americans, NHPI are also part of the model minority myth today. This myth negatively affects the health and well-being of NHPI, not just in health, but in policy, in these social determinants of health we talk about. If we don't know what's going on specifically with NHPI and we group them with Asians, then we can't take action to change that. Okay, so what has led to the model minority myth? Poor data collection practices, limited race-specific reporting, and lack of human subjects research, including minority populations. And I listed some reasons why this has happened, because this was not, this participation in research was a a byproduct of the first project I did with Dr. Nia, and so some things that have hindered this human subjects research are language barriers, small population size, and a history of harmful research conducted on Native Hawaiians and other Pacific Islanders. So data collection is huge, and we mentioned in our breakout session in this room the OMB Office of Management and Budget Directive 15. And so in 1997, Asians and Pacific Islanders were supposed to be split up, and anytime you fill out a form for like identifying your race and ethnicity, except in so this is super interesting to me. So in STD data, HIV data, and TB data, race and ethnicity are collected as one variable. In any other data collection, they're supposed to be collected separately. They can be collected together, but supposed to be collected separately. I think ethnicity is supposed to be listed first. I'm not sure on that. But this creates an issue in that there are coding differences when you get into software. And so even with everyone, if everyone were to go by this new 1997 directive, we have these 5 categories for race, and anything before that, if you have coded it separately, it's going to be a challenge to recode and find the history of this race change. And so that's part of the problem. The more important problem to all of this aggregated data is implementation. It's just not happening. So what I found, I did a lot of interviews so once we decided I couldn't find much data, right? So this was I called everyone. I emailed people, I called people, I found lead investigators listed. I talked to everyone we could think of in Arkansas, county health department. Everyone led me. It was a hunt. And what I found was they couldn't tell me anything about their data because the participation in surveys, in all these things I wanted to know, was so small. So if they don't have more than 5 people in this race group, then they are legally bound not to give it to me. So even if I filled out the request forms, which I'll talk about later, they can't. It's not possible. So we need to be involved. Self-reporting is part of the OMB directive, and I have walked into many hospitals, many doctors' offices, places that are supposed to collect all of this information, and I have never come across what they are supposed to be doing. And what I found, I spoke with hospital administration at Uams, and what they're supposed to do anytime someone comes to the hospital, any of these pathways, they have a sheet. And this sheet says, it gives you these options, and it says, we want you to self-identify. What are you? Like, what do you identify? You can specify as many races as you would like, and they are supposed to hold up this sheet, and you're supposed to say, that's me, that's me, that's me. And if you need language assistance, you should have that. I've never come across one of those in my experience. Not that I am constantly at these places, but I think I should have heard about it in my lifetime. So they said what typically happens is they do train for this. They do train for self-identification for the OMB Directive 15. And new people who start working at these hospitals will do it, will do the appropriate format of this for a few weeks. And then they use visual identification. So what you can do if you go to the hospital is you can be that. You can say, I am a Native Hawaiian Pacific Islander, and this is how I would like to identify. It's not exactly it's actually not at all how it's supposed to work, but that may be what has to happen in these scenarios for them to actually record your race accurately. What I did here, this is another part of the project. So I looked online at just participation in obesity studies on clinicaltrials.gov. You can get, there were hundreds, and I looked at 112 obesity studies. Only 22 of those reported race. So all of these, not only are you supposed to collect the race, you're supposed to report the race, and that is not happening either. So all of this you all know, so race wasn't reported. It was reported in 22 of these studies, and these are published studies. These aren't just people doing anything. They have to meet certain criteria to be on this website, and they have met this criteria. Apparently, race reporting is not part of the criteria, and 0.25% of participation came from an HPI in obesity studies. So I chose obesity because it is an issue that we are dealing with. And so it should have more than 0.25%, but that's where we're at. This is just another example of that participation in research. This is from the 2015 Arkansas Behavioral Risk Factor Surveillance System. People call phones, and those who answer can do this. It is white predominantly, and much older people are answering their phones and agreeing to be surveyed. 0.047% in HPI. That actually is not that bad. So Arkansas, as a whole, the behavioral risk factor surveillance system in the U.S. is much lower than that number, but Arkansas actually captured more than other states. Let's see. So this is for my students out there, whenever I was looking at all of this data, there are some guidelines I looked at. One is it disaggregated by race? It's not. If you find disaggregated data like that, it's a gold mine. Stick with that. Will the sample size be large enough to hold statistical significance? And that they won't release it to you if it has a sample size so small that you can de-identify. So say we're talking about HIV, and it's a sensitive topic, and you have 5 people who have been a part of an HIV study from the Pacific Islands. Well, if a researcher gives you that information, you might be able to work your way through that and de-identify. So they can't give you that. But if the sample size is large enough, typically you will be able to speak with a researcher about that. So all of this quality data, if you're unsure, researchers who have collected this data I've found them willing to talk about it. And depending on where the data is coming from, it will need to meet the collection standards. And you can find out what those standards are and look at the data to see if it's meeting those. Did they collect it by OMB, for example? Directive 15, if it wasn't collected that way, why not? And then this is how This is what we came up with to obtain a data set. So you want to prepare, you need to decide so you prepare, you submit IRB project approval, even if you are not conducting human subjects research. The correct way to go about obtaining data, in my experience, was to submit IRB and say, this is what I'm trying to do, this is what, and they will tell you if you need this approval or not. You need to decide on your population, your condition, your variables, and your data range, and figure out who will have this data. The next page I have is your best bet on finding any data. And then there is a data request form that will ask you all of the questions that you could possibly ever consider answering. And they come with so the codes are specific to whatever condition or variables you need, date range, and you need to understand the codes a little bit. A lead investigator might walk you through them at the organization you're trying to get them from, and you will, there's sometimes a code dictionary if you look on the website. It sounds really complicated with the words they use, but it's not too bad once you get in there and start asking questions. And then these are the places I found that housed the most NHPI data. Again, the data is very limited, but this is where I found any data. And that concludes my presentation. It's all you.
Want to introduce you? Thank you, Courtney. So Courtney was our student. So I just want to motivate all our Pacific Islander students out there that I'm not a bad mentor. So if you want to come over, I can help. I'm not that mean. I know you've been hearing stuff out there. No, I'm not really that mean. But did Tana do your intro and everything? So Tana's fired. So I would like to, the real reason why we do this session, because last year when we had a conference in Arkansas, the students actually, they were hoping to hear more from Pacific Islander healthcare professionals, researcher, and all that kind of stuff. So since we were not able to do it last year, so we did listen to the evaluation, and this year we're very honored to have a physician that was born and raised on the islands. He'll talk more about himself. And then he moved here to go to college, made it to medical school, and help his people and all that wonderful stuff. Because I don't have a bio right now, but without further ado, I would like to introduce a great colleague of mine and also a friend, Dr. Sheldon Riklon.
See. How do I get there? Okay. Good afternoon, everybody. Yahweh. It's always difficult to talk right after lunch because everybody's blood is in the intestines at this point. So not too much blood going to the brain. So I don't blame you for not listening if you don't. But this talk is geared towards the students in the audience. So if you're not a student, you can go out the door and wait. I'm just kidding. JAPSM teaches us, and UMS also teaches us that, we are all lifelong learners. So, we are all students in different respects. I was voluntold by Nia to do this presentation. It's actually the same presentation I did recently at one of the conferences that Dr. Billy Thomas was talking about to the medical students, actually to the high school students in Springdale, as we're trying to recruit and hopefully get some of our students there interested to either go to college at least and, pursue something in the health field. So it's kind of similar. I was thinking that I was going to change it, and I tried, but actually, as I was looking through it, I thought that it was still kind of relevant for our college students to hear about. And actually, a lot of the things that I'll be talking about are my own personal reflections and my thoughts, and what I've come from and where I am today, and just kind of giving you my thoughts into that and advice to the students. And so these are all Sheldon's thoughts, and don't quote me, anybody else. A little bit of personal background. And as Pacific Islanders, it's very uncomfortable to talk about yourself, but I figured it might give us some setting into where I'm coming from as I'm talking to the students. I was born on Ebi, Kwajalein in the Marshall Islands. And if you don't know Ebi, you should. And Ebi is a beautiful place, but it's definitely challenging. And I remember when I was born there, compared to today, is also very different. It's very challenging in a lot of the infrastructures that, that we all take for granted every day wherever we live. I was raised on Majuro after I moved there as, I think I was 5. And then I went to a elementary school. I think it's still in existence, but at the mission school over there. Then I went to a Catholic high school. That's where I went to high school. Then I moved to the Big Island, and that's where I got my BA in biology. Big Island was great. It was just like home without the mountains. But you can go fishing, you can collect coconuts, you can get your breadfruits, it's kind of like back home. So even though I got some scholarships from the Marshall Islands government, it was still limited. So every once in a while, we would go fishing on the weekends so we can have food to eat. I mean, we can have the money to buy the rice, and then we go fishing for our food consumption. So I enjoyed it over there, and actually, I've always tell people that, if we had a medical school in Hilo, that's probably where I would have gone to medical school at, because it was very comfortable for me. Then I came to Manoa, and this is after I had went home for a year, and actually went through the IMI-OLA program, 2 years. And if you're familiar with the IMI-OLA program, it's a program from the John A. Burns School of Medicine that's geared towards Pacific Islanders or those who come from disadvantaged backgrounds, to kind of help you become more competitive as you apply for medical schooling. And normally it's a 1-year program. I had to go through it twice so that I can be more competitive. And when I did apply, then I got into the John A. Burns School of Medicine. So I didn't stop there, even though it was kind of distressful, at times, just knowing that I had to go through EMEA again, which was already challenging. It was very intensive studying, and you basically live at the biomed building on UH Manoa every day. And you get there before the sun gets up, and you go home when the sun is already down. And you come back the next day. You cannot miss a class. If you do, you're already behind. And it was quite intensive that way. And I have one of my classmates here from EME. Then after I went through medical schooling, it took me also a little bit longer to go through medical school. I had my issues that I had to deal with, but I finally graduated. They let me graduate when I paid them to graduate me. Then I went through the family medicine residency program here in Hawaii. So there's a theme here as you're looking at it. All my learning was in the Marshalls and here in Hawaii. Really no plans to move anywhere else but to stay in Hawaii and to go back to the Marshall Islands when I was done. I eventually went back home, worked there for 8 years, then I came back to my Department of Family Medicine here and was working here for a while. Enjoyed working with some of the colleagues who are here. Then eventually I moved to UMS, University of Arkansas for Medical Sciences, Department of Family and Preventive Medicine at the Office of Community Health and Research, and also at the Center for Pacific Islander Health. A lot of acronyms. So that's when I moved there last year. And people still ask me, it's like, why Arkansas? See, Dr. Warmack is like, yeah, I don't get it. But if you had listened to what Dr. Thomas was talking about earlier, and the programs that they have, and the way they're geared towards trying to recruit more island population and people from the Pacific Islands into the programs, that was one of the reasons. I saw that they really were gearing a lot of their programs to get more Pacific Islanders into the colleges and into the schools, and hopefully to get them out. So that was one of the big reasons why I moved to Arkansas. I always like to show this map because I love the map. It really shows the blueness of the Pacific Ocean. And this is really what connects all of us in this room. You know, we come from different Pacific islands right there. Either you're from Micronesia, from Polynesia, Melanesia, all over the Pacific Ocean. And it is the Pacific Ocean that is like the glue that kind of keeps us all together. It is what makes us and our culture very unique. And then, of course, you know, we all go our different separate paths. I like to show this map as well. And this is a map that when I first visited Arkansas about 3 years ago, it was on the wall of the Consul General's office. And all those little blue push pins are where she knew that there were Marshallese at. So she put those push pins. And if you look through that map, we're all over the place. We're in all the different states, and we're in Hawaii as well, and we're in Alaska, and you name it. But that's just Marshallese. If you include all the Pacific Islanders, it's probably even more than that. It amazes me that, you know, we come from the Pacific Ocean and we can adapt to the different environments that we go and live, and we still are able to kind of succeed in what we do. So today, I'm at University of Arkansas, and I work in those different departments, and I enjoy it. I work with interprofessional students along with Dr. Warmack and some of our other colleagues who are here. Work with pharmacy students, medical students, PT students, and APRN students. These students at one of the clinics at the UMS Medical Center, they see Marshallese patients. And actually that clinic is actually a student teaching clinic. So they see these patients for free, and they see them as providers, as team members. They go and talk with the patients, get their history and do the physical exams, utilizing the Marshallese community health workers. I think it's a great system because everybody kind of learns from it. The students learn to know what the culture is. Because if you know, there's an estimated 12 to 14,000 Marshallese in Northwest Arkansas. So at some point, these students will be working with them on the outside. So every year, they're taught Marshallese culture and language so they can kind of understand how do they approach the Marshallese patients. So it's very interesting to kind of utilize the Marshallese CHWs with these professional students and working with the faculty members. I hear a lot of good things about the program because the Marshallese feel like they're understood. And actually, when they come to the clinic, the students greet them in Marshallese and say, Yahweh, Edain, Sheldon, Edam. So they're actually taught the language, and they're also kind of, each time before the start of the clinic, they're oriented to the culture. And they're oriented to what's taboo and what's not, what they can do and they cannot. Not just the clinical stuff, but actually the cultural things as well. And I'm fortunate enough also to kind of work with other Marshallese research assistants, program managers who are actually employed at the University of Arkansas for medical sciences. I think that's a great thing. Because if we're talking about being underrepresented, this is some of the things that we really need to work on, because now we have these Marshallese Pacific Islanders who are actually working at these universities and starting to be researchers. I also work as a family physician, which is one of my great loves in life, being a family physician, because I get to treat the whole patient. And at this CHC, at the community clinic in Springdale, I see a lot of Marshallese patients. I don't just see Marshallese, but I see everybody else. But there's a good number of Marshallese patients that I see. So I speak with them in Marshallese. I have some Marshallese medical assistants that also work with me at the community clinic, along with some Marshallese LPNs. There's also some dental assistants as well. So I feel very blessed to be able to kind of do all that, because that's what, I went to medical school to be a clinician, but I've also kind of morphed a little bit along the years into somebody who does research and do a lot of advocacy stuff as well. And I think, to the students, I think that's some of the things that we need to kind of remember, that you cannot just kind of do one thing. If you really want to do what's best for your community, you got to do other things. You don't have to do research to do research, but it's research to hopefully can kind of form different policies that will eventually benefit your community. So these are some of the personal keys I would think will make you successful in terms of health, research, and practically, I think, life as well. And really, this talk could be given by any of you sitting in the room, okay? Because, but I was given the task, so I will. But really, I'm really young. I'm like 30 years old, like 20 years ago. So this is just my personal views and reflection, what I think as students. I wish as a student that I had kind of known, or maybe I knew, but I just didn't want to believe it. But I think preparation is definitely key. I mean, in whatever you're going to do in life, whatever field or major you're going to go into, prepare yourself. Do your research and really look into it and see what's going to make it happen for you. Gandhi said, live as if you were to die tomorrow. Learn as if you were going to live forever. So if you live every day like it's your last day, then you will prepare yourself. Persevere and persist to overcome. This was really key in getting me to where I could go, or where I am today, because a lot of times I almost gave up, because it was not that easy. And it was much easier just to give up and go somewhere else, and give up and just go home. But if you persevere and you persist, you will overcome, and you will thank yourself. Gandhi also said that strength does not come from winning. Your struggles develop your strengths. When you go through hardships and decide not to surrender, that is strength. So don't surrender. You got the strength in you. I think everybody knows about this one, right? I just gave my flash drive to McGee a few minutes earlier, so I'm the master procrastinator. But, well, I like to practice what I preach, but this is one thing that I haven't really practiced well. So do not procrastinate. Do not procrastinate. That's all I can say. Never leave till tomorrow that which you can do today. Benjamin Franklin. And I think as Pacific Islander students, that's what makes you unique. You should be proud of who you are. And I think everybody here, the last couple of days that we've been listening to the talks, It's been very inspiring to listen to our own people being experts in what they do and the successes and the challenges that they've been doing. It's awesome. It's great to kind of listen to all that. Know your culture. That's what makes you unique. That's what makes us Pacific Islanders. Know your language. Don't lose that. That's very important. Live for one another. I think as Pacific Islanders, that's what we do on a daily basis. It's like it's ingrained in us. So when people don't do that, it feels weird, and you look and like, what kind of person is that? We like to live for somebody else. We like to do things that are better for others. We respect each other. We respect others. We also respect others' cultures. And I think that's part of who we are as Pacific Islanders. Prayers would guide you along your journey. I'm not a religious person. I go to church, usually, sometimes. But, many a times, there will come a time where you're faced with a challenge. And, whatever you try to do is difficult to accomplish. I do not know how many times I've always sat down and prayed for some kind of guidance. And somehow I find my way. So I'm thinking that my prayers were answered. So if you are a religious person, if you believe in God, prayers will definitely guide you along the way. I'm not a preacher either. And Proverbs 1:7, the fear of the Lord is the beginning of knowledge. And I remember this because even as I was a grade student in elementary school, I was always told this, that I need to fear the Lord so I can have more knowledge in me. So these are Sheldon's 5 P's that we just went over. Okay, prepare, persevere, persist, do not procrastinate, pride and prayers. Now this is kind of tacky, but this is what I came up with. These 5 P's represent your 5 fingers in your hand so you can grasp your future and take a hold of it to be successful. Tacky. So what does all that have to do with pathways to a career in health and research? Actually, Nia made up that title. I didn't come up with that title. But I think, all of us are very different. And I think all of us, we come with our unique culture, unique self. So whatever pathway you can take to kind of accomplish and get to where you are, everybody goes in different paths. I have never thought that in October 2017, I'll be in Northwest Arkansas, working at the University of Arkansas for medical sciences. Never in my mind. I mean, I still can't believe it today. But, we are very blessed because, we're very happy there. I mean, I love working there. I love working with the students and residents and the colleagues I have at the university. And I even more enjoy working with the Marshallese community there. I think it's just a unique opportunity that is just like, wow, I should have come here last year. And, it took me a while to really decide, should I go or should I not? My wife said on day one, yes, we're going. And I think they were paying her. I think Uams was paying her to kind of help recruit me because I'm like, what? What's wrong with it? Are you drunk? But she was sold on it, so yeah, of course, and I'm like, okay, fine. You're the boss. So Arkansas is great, and I know part of the reason I want to also kind of tell you in front is, because people keep asking me, and I see a lot of people that I haven't seen for a while, but I'm enjoying life there, and having to work with people also from the Arkansas Coalition of Marshallese, the UMS folks, with Dr. Thomas and the University of Arkansas folks there. It's amazing. I mean, it's amazing. I mean, I can see the potential of what we can do there with the students, with the community. And there's a lot of projects that are coming out of there from UMS, the Department of Research, and from ACOM, and from NIA, and everybody else. And we're hoping that we can expand on that and kind of learn from others, learn from you in what works with you and what didn't work, so we can continue to kind of build on the relationship. I tell people that, Arkansas now is my Marshall Islands because, I'm so comfortable there. And, people joke with me, but, I call the Marshallese there Ozark Islanders. Well, I hope that was inspiring enough for the students to listen to. But of course, if you have any questions, I'm more than happy to kind of help guide anybody. I know I've been approached by a few people who want to hopefully get their students or their kids to come up to Arkansas. But, I like listening to what Dr. Thomas was talking about earlier, because, I think we still have other ways that we can kind of attract the students and hopefully kind of face some of the challenges that we can attract more Pacific Islander students into the university. Como data. Oh, I guess we should be doing Q&A. Yes. Great question about the Marshallese patients I see. It's interesting because, you got your Marshallese patients who've been there for years and have been going to the clinic, but you also have the Marshallese patients who have been there for years and really haven't seen a PCP. And a lot of the patients, especially the new patients, and I'm getting a lot more new Marshallese patients, but, they're so happy when they walk through the door and they see me and they're like, oh, I want to talk to you. I got all these things that I need to talk about. And a lot of it is not understanding what their previous providers were trying to kind of tell them in terms of their medications, in terms of the test they were supposed to undergo. So when I sit down with them and I go over their lab results, or I go over their, radiology results and kind of explain it to them and what do they have, and you can see in their eyes, they're just kind of very happy to kind of understand it. And those patients actually are the ones who actually come back on a regular basis. And they're like, okay, now I get it. This is what I need to do. Okay, I'm going to do that. So, and you see them when they come back and they're actually doing it, and you see their numbers getting better. Not every patient. There's a few who still don't get it. And, it's few, but the challenges, I think, with the Marshallese patients there, I think it's the same also here in Hawaii and other places, is their access to healthcare. And at the community health clinic, it's great because, we go by a sliding scale, but it's still something that they still have to pay for because most of them don't have any insurance. So it's hard to, if you're going to do anything outside of the clinic, then it's going to cost them more. If I send them off for an x-ray or an imaging study or some other stuff or some consultation outside of the clinic. So, I've seen, and I know that, some of the things we've also done at the Marshallese the diabetes clinic, is working on some of the videos in Marshallese where we actually, actually I'm the star in the video. I'm talking in diabetes and how do they check their blood sugars and how do they take their medications. So they're listening to that. So they kind of get it also through that channel as well. So we're trying to kind of find other ways that we can also get to them so they can take better care of themselves. Other questions? Oh, yes.
Far some differences that you see between maybe health outcomes or any maybe differences that could maybe attributed to the environment in Arkansas versus here in terms of maybe some positive items that we could build on to apply to other places where other Pacific Islanders are?
Good question, Davis. Thank you. I don't think I've been there long enough to really know that, but I still see that a lot of the conditions that we still face here or even the islands are still present in Arkansas. And you would think that, if we have better access to more affordable food and things, that you're supposed to be healthier. It still doesn't work that way. And in Arkansas, we actually have 4 or 5 Marshallese stores, and actually owned by Marshallese. And when you walk in, you think that you're on Major or eBay because what's on the shelves is what's in the shelves. So Spam is there, and corned beef and sardines and stuff are there. And so that's where we tend to kind of go do our shopping, in addition to Walmart or the cheap hen chickens over at Tyson's. So, and there's a joke in Arkansas that, people say that the Marshallese only give birth on Saturdays, because every Saturday there's always a birthday party. And it's only on the weekends that they have birthday parties. And they have birthday parties all the time. And, in Arkansas, we have, I think it's about 35 Marshallese churches. So, yeah, so that's some of the things that is very interesting in Arkansas. So if we needed to do anything with the community, we usually go through the pastors. We usually, they're, in addition to ACOM and our community, nonprofit organization, we also go through the, pastors and the churches so we can do things there. But it's a very, my friend Gregory Muscarinic, he was just kind of blown away as an anthropologist, thinking, wow, what is this thing? But it's something different. Other questions?
Kumwal, I would have been more comfortable posing my question in Marshallese, but for the sake of the others, I'll shoot it in English. There is some effort on the part of the Marshallese government that is now showing some positive result in terms of getting more Marshallese doctors to the Marshall Islands. This year, we got 1 back from Taiwan. Next year, I understand we'll be getting 2 more. And the year after that, we'll be getting more. So I guess my question is, and this is to you as to the other University of Arkansas authorities here, what are the chances of putting at least 1 or 2 of these Marshallese doctor just got out of school under the arm of Dr. Sheldon to kind of bring them up? This research thing set up is really a unique opportunity for the island. And I was wondering, are there possibilities there for us to kind of get more doctors into the kind of situation that Dr. Sheldon was fortunate to have experienced? More
Romeo. I don't know if Dr. Thomas has any insight into that.
I think, as I said earlier, we've only had 1 Marshallese student to apply to med school in the last 10 years. And so I think what we have to do is actually, these programs that we're building, that's really the place to start. And Dr. Sheldon can talk about the content of those programs, but that's where we need to start, those high school programs.
But I think he was also asking about the students that graduate from the Taiwan Medical School who are back in the Marshall Islands. If they were to do any further training, are they able to come to UMS?
Mm-hmm. That's a possibility. I think we have to really look at it and see how we can manage that. As I said earlier this morning, I think, to me, this conference has made me think a lot. And I think just to hear you pose that question, I think what we can do as an institution is actually go back and talk about these types of relationships that we can build. So it can be a starting point. I mean, so that is kind of where we would start. Again, just looking at, what we have in Arkansas and what we're trying to do in Arkansas, we could actually tie all of that into bringing other students from other Pacific Island areas. So yeah, we can do that. And what I can say is that when I go back, that's something I'll pose to the dean and to the chancellor, and just to the idea, well, can we develop a partnership, or can we develop MOUs where we bring students that, want to be part of that process? And again, not to get too long about this statement, but I think part of what we can do with students like that, if I can find them and identify them earlier, what I mean by that is if I can get them at the undergraduate level even, high school would be ideal. But for us to make that type of impact, we have to introduce them to the system early. So once you get introduced to the system early, which you can do by enrichment programs, summer enrichment programs, research programs, bring those students to the campus, let them do research during the summer. We can introduce them to the institution, introduce them to the College of Medicine, introduce them to the faculty. And I think you'd have a better chance of getting those students to go through med school, or if you have somebody in med school, getting them to come to do research during the summer and then do a residency. So I think you have to attack it a little bit earlier rather than just saying, well, I have somebody that's finished med school, I want you to help me do whatever with them. So I think if we take a real, I guess, calibrated, direct approach like that, we do much better.
Yeah, and I mean, I certainly agree with the pipeline and all that, and hopefully we get more of the high school students interested in the health field. But I think there also have a few students who already graduated from college that are interested in getting into medicine, and I think the challenge for them is actually to be competitive enough with everybody else who is applying, and especially if they're coming from out of state, then their ranking is not as high. So I think if there could be some kind of special Pacific Islander kind of program geared towards them, or just kind of something similar to what the Emiola program is doing here with our Pacific Islander students, maybe that might be something that we probably should think about. And I was just speaking to another friend earlier, but the reality also of it is also the tuition, right? If they're able to apply for it, they cannot afford it. So even they're smart to get in, it's maybe developing different scholarships for Pacific Islander students that can help pay for their way into medical school.
We can develop a prep program that targets Pacific Islander students. We can do that. I guess, again, we just need to get familiar with, the pool of students, what students we're going to select. But we can actually do that. So we can develop a program.
And then just to let you know, sorry, I'm just finishing up, but it's still really early in the talks, but there might be a program that might be coming to the Marshall Islands, coming from UMS, in terms of residency training that might kind of address that, where the students who are coming back from Taiwan might be able to kind of work with the residents and faculty that will come and visit the Marshall Islands. Who knows? But that's still early in the talks at this point. Okay, I think that's enough.
If we can get a big round of applause for Dr. Sheldon. Thank you, Dr. Sheldon. Very informative. Thank you, everybody that participated. I'm not supposed to, this wasn't part of my voluntold deal, but Tana is missing in action and Nia is missing in action. And the breakout session started 7 minutes ago. So we're just, we have 7 minutes. Oh, okay. So we're going to go ahead and everybody has their choice and knows where to go, correct? So thank you very much and split to class. Thank you.